I'm Dr. Ellie Stein. Welcome to the second of 3 introductory recordings on myalgic encephalomyelitis chronic fatigue syndrome. These recordings may be of interest to patients, family members, supporters, and healthcare professionals. Because the recordings are adapted from a presentation I gave to medical students, I occasionally refer to you, the viewer, as a medical student. Part 1 was titled, What is MECFS? This part is on diagnosis, and the third recording is on how to manage the most common symptoms of MECFS. Thank you for watching. In order to diagnose a condition which doesn't have a diagnostic test, you have to know what to look for. As you ask questions of patients more often, you will begin to identify patterns. In MECFS, the background is complex. There are many symptoms, they are constantly changing, and there is a lot of variability or heterogeneity amongst people with MECFS. Nevertheless, if you know what to look for and what questions to ask, a diagnosis can be made with confidence. Diagnosis by family physicians is both possible and necessary to move patients efficiently into appropriate management. This recording will walk you through some of the questions to ask and what answers are most suggestive of MECFS. Throughout this recording, I include several short audio clips of real patients sharing their lived experience to help you get a sense of what MECFS is like. So just to review the criteria that were mentioned in the video, there's significantly reduced capacity to function, post-exertional malaise, unrefreshing sleep, and at least one of cognitive impairment and orthostatic intolerance. These criteria are recommended for screening purposes, but to kind of really nail down a diagnosis, or certainly for research purposes, we need the more precise Canadian consensus criteria. In these criteria, we have those 5 that were already mentioned, plus chronic widespread pain, endocrine symptoms such as loss of temperature control and loss of resilience to stress, and immune symptoms. You don't have to memorize these. You go to the resource slide, you look up the IACFS ME primer, and these criteria are on pages 12 and 13 of the primer. Now, in this short presentation, I'm not able to go into depth at all about the research that supports these criteria. What are the pathophysiological abnormalities? If you'd like to read more about that, I recommend this short article, 2019 in JAMA, by Anthony Komroff, who's been in the field for more than 30 years. And these studies provide proof that MECFS is real. In order to meet criteria for MECFS, the symptoms I've just reviewed must be present at least 50% of the time and be of moderate, substantial, or severe intensity. In MECFS, patients are often categorized by severity based on what they can accomplish in a day. Patients with moderate symptoms may be able to continue some part-time work or parenting roles. Those with severe symptoms are fully disabled and often need assistance to keep up their residence, procure food, and get to appointments. Those with extreme symptoms, as many as 25% in some surveys, are house or bedbound and need substantial in-home assistance. You will notice in the audio clips that follow, a couple of the patients have a quiet voice, a bit hard to make out. Speaking takes energy. The extremely ill can have difficulty even talking. If you are a healthcare professional assessing a patient who may have MECFS, the first question to ask is what happened when you became ill? Was there a trigger event? Describe the experience when your illness started. In the two audio clips that follow, the first is of someone with a classic acute infectious onset of MECFS. The second is a more insidious gradual onset.
It was my grade 12 year. I was training as an elite athlete, working as a lifeguard, and about to graduate with a Governor General's Medal for academics. I finished the school year and started my full-time summer training feeling weak. One day, I woke covered in sweat, to the feeling that the room was spinning. The same day, I received a positive test result for mononucleosis. My spleen was swollen, so I had to stop training entirely. I remained ill with severe classic viral symptoms for months. Upon some recovery, I tried to begin university. It was a struggle to absorb or retain material. I had to leave and move home. A doctor suggested possible depression. I did not think I was depressed, but it was possible. A second doctor soon diagnosed me with myalgic encephalomyelitis. Within months, I was bedridden and hypersomnic, sleeping 18 or more hours per day. When I was awake, I could no longer read or focus to watch TV. Even short conversations left me exhausted and confused. I was sensitive to sound and light, had a near constant headache, and was always extremely cold. I also had frequent night sweats and dizziness on standing that caused me to crawl if I needed the bathroom. My body was not just fatigued, but profoundly weak. I remained in this state for several years. That was 26 years ago. Since then, my quality of life has improved substantially. However, on a daily basis, I must manage fatigue, weakness, and brain fog. And if I do not, the viral symptoms will flare up.
My illness started with one-offs of tiredness. For example, I would feel extremely tired for 48 hours, and then it would be okay. And this would happen again a month later or so. And the next time I saw my doctor, he told me all my tests were normal and not to worry, but I knew there was something wrong. After that, I started having an insatiable appetite, eating and being hungry all day long, and always hungry and never satisfied. Still able to function, but very odd for me. And then finally I started having sleep issues, which are also very odd for me. But unfortunately, the doctors kept saying that everything was okay.
The next question is asking patients to describe their symptoms. In this video, you see one of the most common symptoms, which is physical exhaustion. A woman trying to climb the stairs, but having to rest partway up.
I am moderately ill with MECFS. I was an active, fit person with a blossoming academic career when I developed a severe viral respiratory infection at Christmas 1992, from which I did not recover. I had overwhelming fatigue. My vision was affected to the point where I could not read, and brain fog was so extensive I could not follow conversations. Memory was also disabled. I was homebound for some years. Although these symptoms have improved, I have never fully recovered, nor have I been able to work full-time, and any form of exertion now leads to a relapse.
And then I asked, how has your daily life changed compared to before you became ill with ME?
Before I got sick in 2019, I used to be an active runner and basketball player. Ever since then, I've been in a dark room, isolated, unable to even feed myself or watch TV due to exhaustion and pain, and just an inner battle to cling on to hope every day that there will be some sort of treatment or cure even.
Often referred to as PEM or PEM, post-exertional malaise is the core symptom of MECFS. It is defined as a worsening of symptoms after physical or mental activity that would not have caused a problem before the illness. PEM is thought to be caused by insufficient cellular energy. It is a worsening of multiple symptoms. It often takes days, weeks, or even months for patients to recover from a PEM crash. To make things more confusing, the onset can be delayed, making it difficult to identify triggers. PEM is the symptom that most limits the ability of patients with MECFS to live a normal life. If you do not experience post-exertional malaise, you are unlikely to have MECFS. In PEM, multiple symptoms like the ones shown in this slide worsen. PEM can be mild, moderate, or severe. Patients with more severe illness are more impacted by PEM. They are hit faster and harder when they try to carry out mental, physical, or emotional activities. Now, post-exertional malaise is the most important symptom, so I'm going to spend an extra minute explaining how to ascertain whether your patients have these symptoms. You want to ask them what happens when you do physical, emotional, or cognitive activity, what kinds of activities trigger you, how long does the crash or symptom exacerbation last, and how has this symptom changed your life?
I'm extremely exhausted really easy. I could just be sitting at the computer recording some of these audio clips as an example, and I've only done a couple and I'm already feeling like I'm gonna fall asleep. I find I have to really manage my energy quite precisely, make a list of what I can do for the day, and it usually takes me a week to a month to recover once I've overdone, and I really wish it wasn't that way because I find that to be really frustrating, and it's discouraging that other people don't understand that I have to rest relatively often, especially between activities.
So you may be wondering, are there any tests, right? The bad news is there's no gold standard diagnostic test. MECFS is a clinical diagnosis. However, if you go to page 14 of the IACFS ME primer, you will see a list of tests there. Those are tests that are recommended to rule out other conditions like hypothyroidism, anemia, autoimmune conditions, etc., with which MECFS may be confused. But please remember, unless your patient has one of these comorbid conditions or alternative diagnoses, the tests will come back normal. Please don't tell the patient, your tests are normal, you're fine. They're not fine. It's just that we don't have the correct tests to order. Now, there are some conditions which commonly co-occur with MECFS. Ask your patient if they have these conditions for two reasons. One, if they have them, some of them are treatable, and you can decrease the patient's suffering by treating these other conditions. And secondly, if a patient has one or more of these conditions, it helps increase your confidence in an MECFS diagnosis because these comorbids are so common. They often have fibromyalgia, which is a fatiguing, severe, aching muscle pain, worse with exertion. They may have pain all over, especially in younger patients. They often have orthostatic intolerance, as was already described in the 5-minute video. They often have chemical and sensory hypersensitivity, meaning they feel more unwell when they're around smells, light, sound, taste, and movement. They're often hypermobile or have Ehlers-Danlos syndrome hypermobility subtype. An increasingly noted comorbidity of MECFS is MCAS, or mast cell activation syndrome. MCAS is a recently described condition which may explain many of the sensitivities so commonly experienced by people with MECFS and multiple chemical sensitivities. In MCAS, the mast cells may be more vulnerable to bursting open and releasing dozens or even hundreds of immune molecules, each of which cause multiple symptoms. Triggers for this include anything that can stress a cell. This includes temperature changes, physical or emotional stress, pain, exercise, fatigue, food, drugs, smells, and insect bites. The symptoms of MCAS are diverse, but the most common include itching, rash, hives, wheezing, shortness of breath, headache, brain fog, digestive symptoms such as diarrhea, abdominal pain and bloating, lightheadedness, and rapid heart rate. Like some of the other comorbidities, there are tests and treatments for MCAS. So if you are a patient, it is worth mentioning these symptoms to your doctor, possibly along with providing them some information on MCAS. Sleep disorders are quite common in MECFS. It is estimated that at least 20% of people with MECFS, when tested, meet criteria for a primary sleep disorder. This includes things like obstructive sleep apnea, periodic limb movements, and more. And there are other common comorbidities. Again, check out the resource pages for more information. Now, it is difficult to differentiate between MECFS and fibromyalgia. About 50% of people who have one of these conditions also meet criteria for the other. However, the research evidence suggests that they're not the same. For example, the genetics and genetic expression and immune function of these two conditions differ significantly. So in the office, what should you ask your patient? MECFS, the core symptom is post-exertional malaise. So that's what you want to focus on. In fibromyalgia, the primary and most disabling symptom is the chronic widespread pain. The reason it's important to differentiate between these two is because the management recommendations are different. If you have MECFS with post-exertional malaise, exercise makes you worse, not better. Please do not recommend it. You will do harm. If the primary diagnosis is FM and they don't have significant post-exertional malaise, then mild to moderate exercise is helpful. Some clinicians also wonder, how can I tell that my patient isn't depressed? Because depressed people also have a lot of fatigue. MECFS and depression have some overlapping symptoms. These include fatigue, brain fog, unrefreshing sleep, and decreased activity levels. But they each have symptoms which don't overlap, and this is how to tell them apart. MECFS is associated with post-exertional malaise. This is not found in depression. People with depression feel better with exercise. As well, people with MECFS have immune and orthostatic symptoms, rarely if ever seen in depression. And in depression, people experience loss of ability to experience pleasure. That's the core symptom of depression. And if that doesn't exist, please don't make the diagnosis. Take-home message: consider MECFS in any patient who has had fatigue that hasn't resolved in at least 3 months and who has the additional symptoms that we've discussed. Please don't shy away from diagnosis. Many patients tell me and report in peer-reviewed literature that it takes 5 years or more to get an accurate diagnosis. In that time, they have no direction. They don't know what they can do to get better. Patients say in research studies that the single most important event that helped them move ahead in accepting, understanding, and dealing with their illness was getting a well thought out, accurate diagnosis. To learn more about diagnosis of MECFS, please check out some of the resources on this slide. The resource page of the US MECFS Clinicians Coalition website includes several key reports on diagnosis and management of MECFS and a consensus on what tests to order to confirm diagnosis. It is a living document, and the intention is to keep it up to date as new science emerges. The National Academy of Medicine or Institute of Medicine Report Guide for Clinicians, Resource 3, lists the questions to ask patients and what answers are most suggestive of MECFS. The Euromean Consensus is a scientific publication on diagnosis, service provision, and care of people with MECFS in Europe. This slide lists some resources for some of the most common comorbidities of MECFS. The Centers for Disease Control Fibromyalgia resource page is a very basic source of information on fibromyalgia. Dysautonomia International is a page with a lot of rich information on orthostatic intolerance and POTS. And the Mastocytosis Society has information on all of the mast cell conditions, including MCAS. I'm Dr. Eleanor Stein. You can find out more information about me and about MECFS, fibromyalgia, environmental sensitivities on my webpage. Thank you for watching.